Welcome. Welcome to the deep dive. Today, we're plunging into something that, well, touches nearly every one of us every single year. Respiratory illnesses. Think about that nagging cough, or that sudden fever. Do you really know what's going on? We've got a fascinating stack of sources here. The latest research, clinical insights, our notes, and our mission today is to cut through some of the confusion. We're going to unpack common culprits like the flu, bronchitis, and a whole bunch of other itis conditions. We'll look at their distinct features, the real risks, and how they're actually managed.
Right, and our promise to you listening in is that you'll walk away not just sort of informed, but genuinely equipped. We'll cover some surprising facts, some really clear distinctions. You might actually rethink how you approach that next sniffle or sore throat. We're here to highlight those crucial aha moments, the insights you just won't get from a quick search online.
Absolutely, because what might look like, similar symptoms on the surface, well, they can actually have wildly different causes.
Yeah.
And need totally different approaches. It's a bit like detective work for your body, isn't it? So, ready? Let's unpack this. And we're starting with the heavyweight champion of annual respiratory illness, influenza, the flu.
Exactly. When we talk about influenza, the flu, we're mostly talking about a virus that travels through the air. Think tiny droplets flying around when someone sneezes or coughs or even just talks or breathes. Less often, it can spread if you touch the surface like a doorknob that's contaminated and then touch your face. And here's something really key. Someone can start shedding the virus, meaning they're infectious, a full 24 to 48 hours before they even feel sick.
Wow, before symptoms even start.
Yeah. Now, the viral load is generally lower than when they're actually sick, but still, it means people can be spreading it without even knowing they have it.
That's a powerful point, isn't it? Really shows why the flu is so tricky to contain. Now, when we say influenza, is it just one type of virus we're dealing with, or is it, more complex?
Oh, it's definitely more complex. Great question. We're primarily concerned with type A and type B viruses. Type A especially is known for causing more severe outbreaks. And you know how we have annual flu seasons, right? Hitting in fall and winter in temperate climates. That's type A and B doing their thing, affecting maybe 10–20% of the global population each year.
10 to 20% globally every year. That's huge. And you mentioned this constant battle idea. What does that mean for how the flu keeps coming back?
Right. That's where two key terms come into play, antigenic drift and antigenic shift. Antigenic drift, that's the small, ongoing genetic changes in the flu virus. Think of it like subtle costume changes, just enough that our immune system's old defenses don't work quite as well, which is why we need a new flu shot every year. This drift causes our annual epidemics.
So that's why the vaccine changes formulation year after year.
Precisely. But then you've got antigenic shift. That's the big one. This is a major sudden change in the virus. Usually happens when a human flu virus swaps genetic material with, say, a bird flu or a swine flu virus. These shifts are much rarer, maybe every few decades, but they can lead to global pandemics like H1N1. Because when a shift happens, our immune systems have very little, sometimes no existing protection, and that can mean higher mortality rates.
That makes a lot of sense. So the flu's always changing. Who really needs to be most worried about serious complications? Is it just older adults?
That's a common thought, but not quite the whole picture. While yes, people 65 and older definitely face the highest risk for severe complications. I mean, tragically, they account for 80–90% of flu-related deaths and a huge chunk of hospitalizations, despite being only 15% of the population. But here's a really crucial aha moment. Children are actually the biggest spreaders.
Really? Children?
Yes. They have the highest infection rates, even if they often have milder symptoms themselves. Think of them as like super vectors, efficiently passing the virus around schools, homes.
So vaccinating kids isn't just about protecting them, it's a massive community protection thing. Okay, beyond the very young and the elderly, who else is in that high-risk group for flu complications?
Well, you've got pregnant individuals, anyone with a weakened immune system, naturally, and residents in group settings like nursing homes or long-term care facilities. Also, people with significant chronic health conditions, think severe asthma, heart disease, kidney or liver problems, diabetes, certain neurological conditions too. They're all at much higher risk for serious outcomes. Oh, and even kids under 19 who are on long-term aspirin therapy.
Okay, let's talk symptoms. If someone gets infected, how quickly does it usually show up and what does it feel like?
The incubation is usually pretty short, maybe 1 to 4 days. Then, especially if you haven't been vaccinated, the symptoms often hit you like a ton of bricks. Abruptly. You'll likely get a fever, often for 3 to 5 days, sometimes up to a week. Chills too. A headache, sometimes feeling like it's behind your eyes, maybe sensitivity to light, just feeling generally awful, malaise, and those deep muscle aches, particularly in the legs and lower back.
Oof. And the respiratory symptoms usually come along with those, right?
Mhm.
The cough and sniffles.
That's right. You might get a runny nose, stuffiness, a sore throat, hoarseness, and that persistent, often dry, non-productive cough. Maybe some soreness under your breastbone. Now, here's another interesting detail. While stomach issues like vomiting or diarrhea are pretty rare in adults with flu, they can actually pop up in maybe 10–20% of young children, especially with influenza B.
Oh, okay, good to know.
And another thing, elderly patients, they can present quite differently.
Yeah.
Sometimes it's just general weakness, lassitude, maybe confusion, often without a fever or the typical respiratory symptoms. So it's not always that classic textbook presentation.
That's really important. So if someone's feeling rough during flu season, how do doctors figure out if it is the flu or something else?
Well, often, clinically. If you have a fever over, say, 38.2 Celsius, about 100.8 Fahrenheit, and a cough during peak flu season, that's highly predictive of influenza in people over 4. So routine testing isn't always done unless someone needs to be hospitalized. While we have rapid molecular tests, they can sometimes give false negatives. Because of that, the CDC actually often recommends that doctors just presume it's flu and treat empirically if they strongly suspect it.
Right. And what does that treatment usually involve? Is it always antivirals?
Not necessarily. For generally healthy patients, supportive care is often enough. Managing symptoms, pain relievers like acetaminophen, plenty of rest, staying hydrated. Antivirals like oseltamivir can be considered for healthy outpatients if you start them within 48 hours of symptoms starting. It might shorten the illness by about a day, maybe. However, antivirals are strongly recommended for anyone hospitalized or at high risk of complications. Ideally, started within 48 hours, but sometimes even later if the patient is really sick. Oseltamivir is a common choice, even for pregnant women.
Got it. So we've talked about treatment once you have it. What about prevention or stopping it if you know you've been exposed?
Yeah, that's where chemoprophylaxis comes in. Basically, using medication before you get sick to prevent it. For instance, oseltamivir can be prescribed to people a year or older if they've had close contact with someone with the flu. Especially if they're in a high-risk group or during an outbreak. It's typically taken daily for about 7 days after the last known exposure. And in places like nursing homes where outbreaks can be really bad, this preventive treatment might go on for at least 2 weeks.
It really drives home why prevention isn't just a nice to have, it's critical. So what's the prognosis usually? And what's the absolute best way to prevent getting the flu in the first place?
For healthy adults and kids, an uncomplicated flu usually clears up in 1 to 7 days. The prognosis is excellent, but as we've said, if you have underlying conditions or you're at the extremes of age or pregnant, hospitalization is much more likely. Sadly, most flu-related deaths are actually due to complications like bacterial pneumonia or the flu making existing conditions like heart disease worse. The absolute gold standard for prevention, the annual influenza vaccine. It's been shown to cut hospitalizations by around 60%. It's recommended for everyone over 6 months old, including pregnant individuals.
Including pregnant women. That's great, protecting both them and their babies. Okay, but there are different types of flu vaccines, right? Okay, it can seem a bit confusing.
It can be, yeah. Let's break it down simply. Broadly, 3 main types. First, inactivated influenza vaccines, or I5Vs. These use a killed virus, so they absolutely cannot give you the flu. They come in various forms. Standard dose, sometimes a needle-free jet injector option for certain ages. There's an adjuvanted version for those over 65 to boost the immune response, and a high-dose option, also for over 65s, which is particularly effective. Many are egg-based, but we also have cell culture-based ones, now completely egg-free.
That's great for people with egg allergies. Okay, what are the other categories?
Second is a recombinant influenza vaccine, Flublock, for adults 18 and older. This one's unique, totally egg-free, uses a different process, focuses only on the key protective bits of the virus. And finally, the live attenuated influenza vaccine, or LAIV. You probably know it as Flumist. That's the nasal spray. It uses a weakened live virus. It's an option for healthy, non-pregnant folks aged 2 to 49.
Right, a nasal spray. Good option for needle phobes. And the ACIP, the CDC's advisory committee, recommends annual vaccination for pretty much everyone over 6 months, correct?
Yes, exactly, including people who are immunocompromised or pregnant. And it's perfectly fine, by the way, to get your flu shot and your COVID-19 vaccine at the same time, just, in different arms or spots. Oh, and for those 65 and older, that high-dose Lay4 is often preferred over the standard dose, especially if they're also taking a statin medication.
Okay. What about side effects? What's common, and are there any reasons someone absolutely shouldn't get the shot?
Common side effects are generally pretty mild. Soreness right where you got the shot, maybe a low fever, some muscle aches, nothing major. The nasal spray might cause some mild cold-like symptoms like a runny nose. Serious reactions like anaphylaxis are extremely rare. Now, reasons not to get it. A severe allergic reaction to a previous flu shot dose is one, or a history of Guillain-Barré syndrome within 6 weeks of a previous flu shot. Also, if you have a high fever with some acute respiratory thing going on, they'll usually wait until you're better, and infants under 6 months old can't receive it.
And what about egg allergies? That used to be a big concern, right?
Yes, and here's a really important update on that. An egg allergy, even a severe one like anaphylaxis, is no longer considered a contraindication for the egg-based inactivated flu vaccines. You can safely get it in a medical setting or just choose one of the egg-free options if you prefer. However, for the live nasal spray vaccine, the LAIV, there are more restrictions. It's not for immunocompromised people, pregnant women, adults 50 and older, or those with certain chronic health conditions.
Phew. Okay, that was a really thorough look at influenza. Clearly much more than just a bad cold.
So we've navigated the complex, always changing world of the flu. But what about that cough, that nagging cough that just won't quit, the one that makes everyone think antibiotics? Let's shift gears to acute bronchitis. Often misunderstood, and there's a really key point here about managing it.
You've hit on something crucial there, acute bronchitis. It's mostly caused by respiratory viruses, the same ones that give you the common cold influenza, parainfluenza, RSV, rhinovirus. Bacteria can cause it, sure, but it's much less common. And yeah, it's most common during the winter months. And what's actually happening inside your airways when you have bronchitis?
Well, essentially, these viruses infect the lining of your main airways, the bronchi. That leads to inflammation, thickening of the bronchial tubes and the windpipe, which can cause a bit of airflow obstruction and make your airways, extra sensitive or hyperresponsive.
So it's the body's reaction causing the symptoms. And what are those classic symptoms?
The absolute hallmark symptom of acute bronchitis is a persistent cough. It can really hang around like 1 to 3 weeks. Initially, it might be dry, but often it becomes productive. You start coughing up mucus. Now, here's a really, really important distinction to make. That mucus might be colored, yellowish or greenish, but that purulent sputum, the colored stuff, it's a non-specific finding. It does not reliably tell us if there's a bacterial infection. And crucially, it doesn't mean antibiotics are going to help.
That's huge. That's a massive aha moment right there. Given how often people think colored phlegm equals bacteria equals antibiotics, what other symptoms might someone have? And what's usually missing?
You might get some general cold symptoms alongside it: runny nose, sore throat, mild headache, feeling a bit unwell. These might come before the cough or during it. But here's another key distinction. A high fever is rare in acute bronchitis. You might also get some wheezing, maybe mild shortness of breath with the cough. When a doctor listens to your chest, it might sound clear, or maybe some wheezing or raunchy that often clear up after you cough.
Okay. So how do doctors usually diagnose this? With a lot of testing needed.
Mostly, it's a clinical diagnosis based on the story. The doctor looks for that acute onset, that persistent cough, but critically without the signs that point towards pneumonia. Things like high fever, really fast breathing, or specific lung sounds suggesting consolidation. If your vital signs are normal and pneumonia isn't strongly suspected, usually no further tests like a chest x-ray are needed. An x-ray is typically only done if the doctor can't confidently rule out pneumonia based on the exam, especially if you have abnormal vitals or maybe changes in mental status if you're an older patient.
So if it's mostly viral and doesn't usually need lots of tests, what's the treatment plan?
This is probably the most crucial point about bronchitis. Supportive care is the absolute mainstay. Acute bronchitis is almost always self-limited. Your body clears it on its own in 1 to 3 weeks. So treatment is all about symptom relief. Staying hydrated, maybe using over-the-counter cough suppressants or expectorants, pain relievers like acetaminophen for any aches, and simple things like throat lozenges or hot tea can actually provide quite a bit of relief.
And this brings us back to that big misconception. Does this mean we should generally avoid antibiotics for acute bronchitis?
Precisely. And this is so important for everyone listening. Antibiotics simply do not provide significant benefit in most cases of acute bronchitis in otherwise healthy adults. Why? Because, like we said, it's overwhelmingly viral. And overprescribing antibiotics when they aren't needed is a huge driver of antibiotic resistance, which is a major global health threat. So resisting that urge for antibiotics, unless your doctor specifically identifies a bacterial cause, is actually the responsible thing to do.
That's a really powerful message. Okay, let's pivot now. From bronchitis to something that sounds, well, a bit similar but is far more serious. Epiglottitis, also called supraglottitis. This one's an airway emergency, especially in kids, right?
Absolutely. Epiglottitis is inflammation of the epiglottis, that little flap of cartilage at the base of the tongue that covers your windpipe when you swallow. Historically, the big culprit was Haemophilus influenza B, or Hib, especially in young children. But thanks to the Hib vaccine, thankfully, its incidence has plummeted in places like the US. Now, if we do see it, especially in vaccinated kids, we suspect other bacteria more often, like Streptococcus species.
And what's happening physiologically that makes it such an urgent emergency?
Well, it's a serious and often very rapidly progressive infection. The epiglottis swells up dramatically, sometimes very quickly. This swelling narrows the airway opening, potentially leading to severe airflow obstruction and respiratory distress. It can deteriorate incredibly fast, which is why it's life-threatening.
What are the absolute telltale signs? How would someone recognize this might be happening?
The onset is usually rapid and often marked by what we call the 3Ds. Dysphagia, extreme difficulty swallowing, drooling because they literally can't swallow their saliva, and distress, severe respiratory distress. Patients often have a very high fever, a terrible sore throat, and you might hear inspiratory stridor, that harsh, high-pitched noise when they breathe in. Their voice might sound muffled, like they have a hot potato in their mouth. They look incredibly ill, anxious, restless. Children might adopt a specific posture, the tripod or sniffing position, leaning forward, neck extended, trying to open their airway.
That's a very vivid and scary picture. And I recall a critical warning about trying to examine the throat in these situations.
You're absolutely right. This is a critical safety warning. In young children suspected of epiglottitis, you must avoid trying to look at their throat with a tongue depressor or anything similar. It can trigger a spasm, laryngospasm, leading to complete airway closure, and immediate catastrophe. Diagnosis is mainly clinical, based on those severe symptoms. We deliberately avoid things like blood tests in kids until the airway is secured because any agitation can make their breathing worse.
So how is it definitively diagnosed then, if you can't just peek in the throat?
The definitive diagnosis comes from actually visualizing the epiglottis, usually via laryngoscopy. What the doctor sees is a severely swollen, bright red epiglottis, often described as cherry red. But this is done only when the medical team is fully prepared to secure the airway immediately, often in an operating room setting. If and only if the patient is stable enough, a lateral neck x-ray might show an enlarged epiglottis. We call it the thumb sign or thumbprint sign because it looks like a thumb pressing into the airway space.
And given it's such an emergency, what is the absolute top priority for management?
The single most important thing is securing and maintaining the airway, period. Airway control has to come before any detailed diagnostic workup, especially if there are signs of near total or total airway obstruction. Once the airway is stable, then antibiotics are started, usually strong, broad-spectrum ones, sometimes covering Staphylococcus specifically.
And prevention, besides the vaccine.
Well, the routine Hib vaccine is the cornerstone of prevention. It's been incredibly effective. For close contacts of someone diagnosed with Hib epiglottitis, sometimes preventive antibiotics like rifampin are given.
Okay, that's definitely a serious one. Let's move to laryngotracheitis, much more commonly known as croup. This one often has a very distinctive sound, doesn't it?
It certainly does. Croup involves inflammation of the larynx, the voice box, the trachea windpipe, and the subglottic area just below the vocal cords. And yes, it produces a very characteristic sound, a harsh, seal-like barking cough, along with inspiratory stridor, that noisy breathing on the way in, and hoarseness.
What usually causes croup? Is it bacterial like epiglottitis?
No, croup is typically viral. The most common culprit by far is parainfluenza virus type 1. Type 2 can cause milder outbreaks sometimes. Other viruses can do it too, like adenovirus, RSV, even flu viruses sometimes.
And how does that viral inflammation lead to those specific sounds?
Well, the virus infects the lining of the nose and throat, then spreads down to the larynx and trachea. This causes swelling, particularly in that narrowest part of a child's airway, the subglottic region, just below the vocal cords. This narrowing creates a partial blockage, makes breathing harder, and causes that turbulent, noisy airflow we hear as stridor, plus the signature barking cough.
Got it. I can picture that narrowing now. And who typically gets croup?
It's most common in younger children, usually under 6 years old. It really peaks between about 6 months and 3 years of age, and you tend to see more cases in the fall or early winter.
So that classic barking cough is the main thing. What other symptoms should parents watch for?
Absolutely. That harsh seal-like bark is key, especially in infants and toddlers. You'll also hear the inspiratory stridor, that high-pitched sound when they breathe in. Hoarseness is common, and maybe a low-grade fever. Interestingly, the symptoms often seem to get worse at night. Many kids might also have had some regular cold symptoms, like a runny nose, for a day or so before the croup symptoms really kick in. While it's usually mild, severe croup can lead to significant airway obstruction and respiratory distress.
How's croup diagnosed? Do they need x-rays for this one?
Usually not. It's primarily a clinical diagnosis based on those typical symptoms and sounds, especially once you've ruled out more serious things like epiglottitis or a foreign object aspiration. Crucially, neither x-rays nor lab tests are generally needed to diagnose croup. While a frontal neck x-ray might show something called a steeple sign, that narrowing of the airway looking like a church steeple, it only shows up in about half the cases and isn't routinely done because the diagnosis is usually clear without it. Doctors often use a scoring system, the Wesley Croup score, to gauge how severe it is.
Okay, so if x-rays aren't usually needed, what is the most effective treatment?
The best initial and primary treatment for all stages of croup, mild to severe, is glucocorticoids. Something like dexamethasone, often given as a single dose, either orally, IV, or as a shot. These steroids work wonders by reducing the inflammation and swelling in the airway. They lead to faster symptom relief, often within 6 hours, fewer hospital stays, and less chance of relapse.
That's really good to know. Steroids are key. What about supportive care? Mist tents and things.
Supportive care is definitely important too. Things like cool humidified air mist might help soothe the airways. Fever reducers like acetaminophen are good, and making sure the child drinks enough fluids is important to prevent dehydration. If oxygen levels are low, they'll get supplemental oxygen, often using a blow-by technique, which is less upsetting for kids than a mask. Oh, and nebulized epinephrine, that's reserved as an add-on treatment for moderate to severe croup. It gives rapid but temporary relief within about an hour by shrinking the swelling.
So for most cases, which I understand are usually mild, they could probably be managed at home after seeing a doctor.
Exactly. The vast majority, over 85% of kids, present with mild croup. They typically get their dose of steroid, maybe some supportive care advice, and can go home. For moderate cases, they'll get the steroid, maybe the nebulized epinephrine, and supportive care. They're usually observed for a few hours, and if they improve significantly, they can often go home too.
Okay. Now, you mentioned bacterial tracheitis earlier, sometimes called bacterial croup. Sounds like a serious mimic.
It is. Bacterial tracheitis is rare, thankfully, but it's a very serious condition. It's an invasive bacterial infection causing inflammation and pus in the soft tissues of the trachea. The most common bacteria involved is Staphylococcus aureus. It can happen on its own, or sometimes it develops as a dangerous complication on top of viral croup.
How would a parent or doctor spot the difference if the initial symptoms seem like viral croup?
While the symptoms might seem similar, initially cough, straight or the key difference is that the child with bacterial tracheitis will appear toxic, very ill. If it's complicating viral croup, the child might have had typical croup symptoms first. But then they take a sharp turn for the worse, developing high fevers, that toxic appearance, a severe cough, worsening stridor, and significant respiratory distress. It's a true airway emergency.
And diagnosis and management for something that severe.
Diagnosis can be tough. An X-ray might just show nonspecific swelling or irregularities in the trachea wall. Management often involves racemic nebulized epinephrine to help open the airway, just like in severe croup. And because it's bacterial, immediate, strong, empiric antibiotics are absolutely critical. They'll usually start with vancomycin plus a powerful third-generation cephalosporin or a similar strong combination to cover the likely bacteria right away.
That's a sobering reminder of how crucial it is to distinguish these things, especially when they get serious. Okay, finally, let's turn to acute bronchiolitis. This is often seen in the very youngest patients, right?
Yes, acute bronchiolitis is an infection and inflammation specifically of the smallest airways in the lungs, the bronchioles. Respiratory syncytial virus, RSV, is the most common cause by a long shot, followed by rhinovirus, which is another common cold virus. Other viruses can cause it too.
And who's most at risk for getting bronchiolitis?
It most commonly affects infants, usually from about 2 months up to 2 years of age. We see it most often during the fall and winter. Babies under 6 months are at higher risk for more severe disease. Other risk factors include exposure to cigarette smoke, not being breastfed, being born prematurely, or being in crowded places like daycare.
So what exactly is happening down in those tiny airways that causes such significant breathing problems?
Well, the virus first infects the upper airways, like the nose and throat. Then it travels down to the lower respiratory tract, specifically attacking those tiny terminal bronchiolar cells. This direct viral damage causes inflammation, which leads to swelling, a lot of extra mucus production, and shedding of dead cells. This combination, sometimes with a bit of bronchospasm too, obstructs those small airways. That causes air trapping and hyperinflation lower down in the lungs, which ultimately leads to the respiratory distress we see.
And what do those symptoms look like for a parent?
It often starts like a regular cold, what we call a viral URI prodrome, maybe a low-grade fever, runny nose, congestion for a day or three. Then, usually around day 2 or 3, the lower respiratory infection symptoms kick in, causing noticeable respiratory distress. You'll hear wheezing, maybe crackles or rales in the lungs, and you'll see signs like fast breathing, nasal flaring, grunting sounds, the chest pulling in with breaths, retractions, and breathing out taking longer. Symptoms usually peak around days 3 to 5 and then gradually start to get better.
What are the red flags, the signs that indicate it's a more severe case?
Signs of severity would include low oxygen levels, hypoxemia, scary pauses in breathing called apnea, especially common in infants under 6 weeks. Also, poor feeding because they're working too hard to breathe, or just obvious signs of respiratory failure. Diagnosis is mainly clinical based on the history and what the doctor sees and hears on examination. Routine tests like chest x-rays or blood work are generally not recommended unless the doctor strongly suspects a serious secondary bacterial infection. Actually, the single best predictor of how severe the illness is in kids is pulse oximetry, measuring their oxygen saturation.
Okay, so if routine tests aren't usually needed, what's the treatment? Is it like bronchitis, mostly supportive care?
Yes, absolutely. Supportive care is the undisputed mainstay of treatment for bronchiolitis. This means making sure the child stays well hydrated. Sometimes that means carefully tracking fluids, sometimes IV fluids if they can't drink enough. Relieving nasal congestion with bulb suctioning or saline drops is really important so they can breathe and feed more easily. Providing supplemental oxygen if their levels are low, usually below 90–92%, and sometimes more advanced respiratory support like heated high-flow nasal cannulas or CPAP to help reduce the work of breathing. Plus, fever reducers like acetaminophen for comfort. The main goal is monitoring and supporting them while their body fights the virus.
Are medications like bronchodilators or steroids commonly used?
This is another crucial point, similar to bronchitis. Medications actually play a very limited role in typical bronchiolitis. Things like nebulized hypertonic saline, inhaled bronchodilators like albuterol, epinephrine, and antibiotics are not routinely used. Why? Because multiple studies have shown they just don't significantly improve outcomes for most children with bronchiolitis. And corticosteroids, they are generally not indicated for a first episode of bronchiolitis unless the child has a known history of underlying asthma or reactive airway disease. The focus really is overwhelmingly on that supportive care.
So for bronchiolitis, it's mostly about helping the body heal itself. What about prevention, especially for those high-risk babies?
Right. For very high-risk infants, like those born very prematurely, or with certain chronic lung issues or congenital heart problems, there is an option for immunoprophylaxis. It's a special monoclonal antibody called palivizumab. It can be given as monthly shots during RSV season, usually in their first year of life, to help prevent severe RSV disease. And of course, simple things like really good hand washing are incredibly important for limiting the spread of RSV and all these respiratory viruses. Plus, recently, new RSV vaccines have become available for certain groups, adding another layer of prevention.
Wow, what a journey through the respiratory system. It's truly incredible, isn't it? How many different things can cause something that seems as simple as a cough or a fever, and how differently each one needs to be understood and managed. We've gone from the huge annual impact of the flu to the very specific life-threatening danger of epiglottitis, and those subtle but really critical differences between bronchitis and bronchiolitis.
Indeed. And knowing those specific characteristics, the cherry red epiglottis, the steeple sign of croup, or that really key point about not needing antibiotics for most bronchitis, it truly helps us appreciate the precision that's needed in managing these illnesses. It really makes you think differently about how having the right information empowers us, both clinicians and patients, which raises an important question.
So what does all this mean for us? Where do we go from here?
Well, given that the initial symptoms of all these different conditions can often look so similar, what new approaches could we develop? Maybe leveraging more advanced rapid diagnostics, or perhaps more creative public health education strategies. How can we truly empower individuals and communities to better distinguish between these things earlier, and to prevent and manage them more effectively, moving beyond just reacting once symptoms are severe?
That's definitely something for all of you to mull over as you navigate your now even more well-informed world. Thanks so much for diving deep with us today.